Welcome to PSG Health Insights. Much has been written and reported in the media on government's plan to implement national health insurance. Some say that it is possible, whilst others say the obstacles are just too insurmountable. But what do those in the know think? John Cranke, Head of Healthcare for PSG Konsult Corporate, poses critical questions to representatives from three of the largest open medical schemes in South Africa regarding the impact and plausibility of national health insurance.
Morning, Damian. Thanks for joining us.
Thanks, John. Thanks for having us.
It's accepted that NHI is going to be phased in over a period. The Green Paper spoke about a 14-year period, with three distinct phases. And more recently, the National Development Plan spoke to a period that as long as 25% due to the scope of the project. In your view, when do you think NHI is going to start impacting on the medical schemes themselves?
John, it's an interesting question, I think, an interesting debate. If you look at NHI just generally across the world, in some places it's taken over 100 years to implement. So I think what we're seeing in South Africa now is a more realistic view. Originally when we started talking NHI, it was going to be done in the next 5 years. And now we're seeing a more realistic view of how and when. I think it's going to be uniquely South African. I think my central theme, I guess, around NHI is we're going to find a uniquely South African answer to what is going to become a uniquely South African problem. We have a very different social demographic issue, we have a very different profile, we have a different rate of unemployment than what you see in the rest of the world. So I expect it to take that length of time. I think if you look at where we are now and the pilot phases that have been implemented, I think that's probably the right step. So we're seeing a phased in process. To a certain extent, it's already impacting medical schemes. NHI by definition should be a healthcare coverage for everybody, and it's a sort of guaranteed acceptance for everybody. Yeah. To a certain extent in South Africa, we have an NHI model. It's healthcare is free for pregnant people and children under the age of 6. And I think that's more what we're going to see. We're going to see more phased-in approaches like that, and NHI working alongside medical schemes rather than NHI and no medical scheme overnight. I think you'll see a phased-in approach, and we're already starting to see some of the impact. PMBs, as an example, could be defined as an impact of NHI or the roadmap towards NHI. So yeah, I think to a certain extent it's already started, but not in the way in which we define NHI. NHI as an all-encompassing healthcare coverage for everybody. That I think will take a look, maybe even longer than what the Green Paper is already indicating.
Thanks. One of the aims of NHI, and the Minister of Health has been very vociferous about this, is to try to bring the rising costs in the private healthcare space under control. And he's been, as I said, pretty vocal about it. In your view, is this realistic, and where do you expect to see the first pressures translated to the medical schemes?
John, I think if you look at the Department of Health anyway, in the absence of NHI, they're trying to drive down the cost within the private healthcare space. So I think if you take an NHI world, you'll probably look at them saying as a bigger single purchase of healthcare in South Africa being the government, they will probably look to drive costs down through negotiating power, through other components, as a large scheme to be able to negotiate with providers. So I expect it in that area, I expect it in the negotiation area, but I also think they'd want the admin costs to be lower within the administration space. Now, whether they can do that cheaper than what their industry is administering private healthcare, I don't know. It's going to depend on the skills and resources and components that they have within that environment. But even in the absence of NHI, one of the drivers in Momentum's environment is to ensure that the cost of private healthcare is reduced. So the ability for us to negotiate with provider and then have something meaningful in the provider-funder relationship that is meaningful for them, but also meaningful for the consumer, ultimately as the end consumer of healthcare. But also in the cost of the non-healthcare costs, if I can call it that, which, again, if you look at the Council of Medical Schemes report, there's focuses on all of those components within the private healthcare industry. Now, we've been quite successful in reducing the costs within that environment in real terms, and we'll continue to do that because we think it's the right thing to do. Consumers shouldn't be paying for massive increases in the non-healthcare costs. More of their rand should be going to healthcare spend. So one of our drives is to ensure that continues to happen. But I do think that a bigger scheme, if you like, an NHI super scheme, if you want, which is bigger than anything we've seen in South Africa anyway, will hopefully be able to drive down costs through its negotiating power with the whole industry. Whether we see that in reality is going to determine on how well government administers the whole component of it, the ability for it to negotiate with providers. But South Africa has a unique problem. We don't have as many providers as the rest of the world. If you go to the States, there's hundreds of providers and a few members. In our world, it's the other way around. There's a few doctors and hundreds of members. And now who has the negotiating power? So we need to ensure that we still have a really good quality of provider base within the South African basis in which to be able to provide an NHI or a private healthcare system. So there's lots of things that will influence that. But I think costs, even in the absence of NHI, as schemes and administrators, we have to make sure that we drive those costs down as well as we can, and to reasonable levels, obviously. And it's something that we be focusing on even without NHI being in the place.
So in your view, would NHI and medical schemes be able to coexist both now and going into the future? Is it more a transitory kind of arrangement, or do you think it would be a permanent long-term solution?
John, if I look at the rest of the world, if you look at Germany, Australia, Spain, Thailand, or in fact a lot of the countries where you see really established NHI models, about 10 to 20%, depending on the country, still has, even in a solid NHI environment where there's almost coverage for everybody, very wide coverage, you still find between 10 and 20% of people buying some form of private healthcare. And I use the word insurance here, but they buy some form of top-up insurance cover. I think in South Africa we're going to see that insurance, the basis of that insurance, at least in the transitionary phases, be the private medical scheme industry as we know it. We know the regulator is not that comfortable with insurance-based products in the healthcare space competing with medical schemes, so we see a little different way in which we're going to evolve into that phase. But I do believe that the two will be able to operate together. A lot of South Africans, in fact, the vast majority of the people in the private healthcare industry will still want some kind of top-up insurance to beef up, or to top up NHI. So I think you'll still see that. So I do believe they'll be able to coexist. I think there'll be regulations in terms of what you'll be able to do on top of NHI. So I think the regulatory environment in which the schemes are currently playing will change, but it will allow for a private healthcare model to sit next to NHI. Whether that private healthcare model is a medical scheme or not, I think that we'll only see a little bit later, and we're quite comfortable there. We think we must have products, and we do things like Health Saver that sit outside of the medical scheme but provide healthcare coverage for for people. So we'll continue to look to have products that can sit around that, and for that matter, whether it's an NHI or non-NHI environment, we must still have relevant product that can cater for people within that environment.
One of the early predictions coming out of the people inside the industry looking at the green paper is to say that one of the expected consequences of implementation of NHI would be that the young and healthy members and also, for that matter, the low-income members would fall out of the medical schemes because they'd be satisfied on one hand with the benefits in NHI, or wouldn't be able to duplicate the private healthcare cover that they currently have in addition to funding NHI. This, of course, undermines a lot of what the private medical schemes are doing at the moment, or the open medical schemes, in that they're working, and particularly in your case, at trying to attract a younger, healthier profile member into the scheme. So the question really goes around, what are you doing to position yourself for that in future, and are you happy to share with us any of those things right now?
John, I think the first part of that is, do we expect all the healthy people to leave schemes and go into NHI, or do we expect all the low income and all those other components? If you look at the industry, it's a very mature industry. The healthcare industry, to be fair, outside of GEMS, hasn't really grown. It's been more around, and there's been small growth, but I mean, in the 20 years I've been in the industry, the growth is relatively negligible. Let's just kind of say that. Most of the growth that we have seen is in the low income space. Now, that's not necessarily young, and it's not necessarily old, it's low income. So if we assume that low income earners will buy out, because I think that's more the thing, not necessarily younger members, I think it's more low income earners who will buy out of the industry. What are we left with? Because that's where a lot of our new entrants come into. And that's where a lot of the medical schemes today, ours and some of the other bigger players, are actually growing in the low income space. If those members are all of a sudden not in, the industry just remains a very mature, aging industry. So I think a lot of the low income members, because they will get it for free, won't pay for it twice. And I think that that comment is very, very valid. The question is, will young members still buy and still see the need for insurance? I still think that's the case if you can make it viable for them, if they see value in buying that insurance. The same way you would buy value, young people buy car insurance. They don't buy it in the same way that someone who's older buys it, but they will buy the car insurance that's appropriate for them. So you have to have product. Now, whether that's in medical scheme or not, as we just, we debated a little bit earlier, but you have to have product that is able to cater for low income. Now, we have already designed a lot of product that sits within that environment. So things like Health Saver, Health Returns, those provider choice components that sit within our medical scheme are designed to attract young, healthy people in the marketplace, and we'll continue to push the envelope in those. Yeah. That's where I think the innovation really needs to be. If you want to be successful in this industry, it's about attracting young, healthy lives. And at the same time, provide meaningful benefit for the people that have been in your scheme for a long period of time and have that good cross-subsidy mix. So just before launch, I can't share obviously a hang of a lot with you around what we want to do within those environments, but I think our track record demonstrates that. We have been a very innovative scheme, and we've demonstrated things like health returns, health saver, health platform. There's a lot of components that sit and speak to healthy people, healthy companies, but at the same time still provide good value for people who require those benefits.
Thanks. So you made some good points there indeed. So presuming the successful implementation of NHI, whenever that happens, what in your view would be the way in which a current medical scheme is configured, and do you think there, for instance, would be a departure from the current scenario where you have an open enrollment, community rating sort of environment, to more health insurance centric products to potentially supplement what's going on in NHI?
John, it's a difficult one because you don't know how far NHI is going to stretch. I would assume, let's say we take what's happened in the rest of the world, then the medical schemes as they stand today probably look like they won't have a place. But if you look at where the regulator is saying, I think the regulator wants the medical scheme industry to play in the spaces where insurance plays in the rest of the world. So some of the principles may change. You may have less open enrollment, you may have risk rating premiums, although given where our regulators are, I don't necessarily think that that's the way they want to go. I think they want a more cross-subsidized medical scheme or top-up insurance type of component available. That will largely depend on kind of where the regulation goes, and it's difficult to say, once NHI is implemented, that in itself could be 25, 30 years from now, and you might see a very different set of a regulatory mindset. But in our current environment, I think the medical schemes and NHI can play very well together. A lot of people are quite anti-NHI, and I don't necessarily think we need to be. It is really, really needed in South Africa. If you look at the South African context, the vast majority of South Africans don't have healthcare cover, don't have access to healthcare cover. And that's actually quite sad. I mean, for all of us as South Africans, we want our fellow South Africans to have the need to have healthcare cover. So we need NHI. There's absolutely no doubt. The healthcare industry hasn't stretched far enough, the private industry hasn't stretched far enough into the lower income segments, and for that matter, the unemployed. So there needs to be some kind of component which can meet those requirements. And I think that's why those 10 pilot districts are so critical to the success of this. We're going to learn a hang of a lot from the manner in which NHI can be implemented. And you might find that we have NHI for a while in the rural areas of South Africa, with the people who don't have access to doctors and things that we're used to having access to. Some studies that we did, and it's some time ago, but more than 50% of our nurses practice in the private sector, which is maybe covering 7 or 8 million out of 50. And that's a good number. Dentists is probably more than 95% of our dentists are practicing in the private sector. So we've got 5 or 10% of our dentists looking after the vast majority of our population. So we have to address those imbalances. And I think NHI is designed to try and do that. Yes, it's going to impact the private healthcare industry, but it doesn't have to impact it in a way that all of a sudden the private healthcare industry, which is a really good set of private healthcare that we have available if you compare it to the rest of the world, has to be that badly detrimented. I think the two can definitely play together. And I think we can work towards making it play. It doesn't have to be a negative.
Thanks, Damian. Well put. And on that score, the National Development Plan highlighted the fact that public-private partnerships are going to be crucial in the implementation period. How do you see the medical schemes playing a role here? Because often the thoughts go around providers and the resources, human resources particularly, to underpin NHI. Can the medical schemes play a role there?
I think absolutely, and I think we have to. If you take government as an institution, what experience do government employees currently have in administering medical schemes or providing risk management or underwriting or pricing? There's a lot of that experience that sits in the private sector. So yes, absolutely, the negotiations with providers and all that will happen at a government level, but the ability to administer a 40 million member medical scheme in a South African context is a really big ask. Those skills exist within South Africa and exist very well. I think if you look at where the private healthcare industries come from and the technology that's available today in systems, in people, in IP, in product design, we can really sit together and make a massive difference in how these structures are set up and share a lot of skill and resource with government in managing those medical schemes or the NHI medical scheme, if you like. So absolutely, I think there's a lot of work that can be done to assist, just simple things like systems, pharmaceutical payment systems, so there's a lot of technology that already exists and knowledge that already exists that you don't have to rebuild. You can work together to make good sense of it. And I think those are some of the areas where the funding side of it and the administration side can work very closely with government to ensure that it's smoother. One thing none of us want, any of us, we submit a claim to an NHR system or to a medical scheme in the private sector and we don't know where the claim's gone.
Yeah.
That's going to just undermine all of those structures and all of those components. So we actually want the thing to work. So I think if we can share skill, and naturally I think that sharing of skill will happen. I think like anything, there's a little bit of a, do we want to share everything? Don't we want to share everything? Are they a competitor? Are they not? But I don't think we must see it that way. I think we've got to look at it and say, we want the best possible healthcare for our country. And what is the best possible solutions with which to do that? And sometimes we have to put our own profit motives aside and say, how do we actually get about doing that? Because if we do the right thing, money will flow anyway. I don't think we have to look at it as it's a them and an us. I really think we have to look at it totally differently and say, private healthcare and the national healthcare system can work, and they work across the world together. How do we make ours work the best together? And I think the sharing of skill and knowledge can definitely be part of the public-private partnerships that we can get to make it work.
Thanks, Damian. The message I'm getting here loud and clear is that NHI doesn't spell the end for medical schemes. It's not all doom and gloom. There definitely is a role to play. Just stepping off NHI for a moment, what are the current major threats, in your opinion, facing your medical scheme that you're in the process of addressing? Sorry.
Yeah, I think, John, in a mature industry, in an environment where we almost compete with another medical scheme all the time. You kind of compete with one another. You're not necessarily growing the pot. One of the key things for any medical scheme is profile. And if you can manage profile in your medical scheme, you have a better strength or long-term sustainability. That will give you your best future claims indicator or your best future claims cost. And making schemes attractive to young people who feel that they're bulletproof, they don't feel like they're ever going to get sick, and they can join a scheme early enough is important. And we see it in some of the financial positions of medical schemes, even running into sort of the 2013 years, is some of the claiming patterns within those schemes are under pressure. So we think that managing the profile, having relevant benefit for a younger member, while still providing meaningful benefit for an older member, are some of the challenges that we face. The cost of medical schemes, I think, is a challenge as well. We see inflation plus 3% if we're in a good year. Sometimes it's plus 4 or 5%, and people can't keep affording to do that. So if you look at what's happening in our industry, people are buying down. People are opting out of their kind of comprehensive plans, and they're buying hospital plans and self-insuring a large portion of their healthcare cost. And we don't think that's right. We don't think people should be self-insuring. You're buying a medical scheme to protect you. So it's having meaningful product that members can use flexibly to meet their unique need. Too many times we see in the industry saying, well, you older, you must buy this. It shouldn't be you older or you younger. It's what do you actually need? And I know you and I have discussed this many times in our personal spaces, to say, what do you actually need, and build the product that can cater to that individual the best possible way. And I think we do that better than anybody else. We've got some really flexible components within our product. You can buy a hospital plan within our environment and get day-to-day cover for free. You can't do that anywhere else. So in our space, it's those types of challenges. How do we still be meaningful in an industry which is quite mature? How do we attract young, healthy lives within our scheme that gives our membership that's currently in the scheme some security and stability going forward into the years ahead, but at the same time do it at a price that still remains relevant? And I think those are some of the balancing acts that we all have to do within the industry.
What has your scheme's experience been regarding the members' ability to access providers, and particularly now in the absence of tariff agreements? We know the health professionals tariff guideline recently has been withdrawn and still under discussion, so that's probably off or out of play until next year at some point. And in the absence of that tariff agreement, how have you found your ability to be able to negotiate with provider groups to set up designated service provider arrangements?
John, I think we've been very, very successful. If you take the benefit design of Momentum Health since its inception, it's always had negotiations with providers as one of its core features. And the provider choice component that we've had within the risk components of the product has been very, very successful. So As an example, you can go to any provider you like for hospital and you can use one of the network providers as well. We do it in our low income options. You can choose a state network and make your premium cheaper, or you can choose a private network. So we have provider components and provider negotiations right across all of our DNA, if you like, within the medical scheme. And I don't necessarily think we're finding it any more difficult or any more easy, I guess. It's just part of our DNA. So it's as a result that it may become more natural to us than what it does to some of the other players within the environment, because it's always been part of what we do. We are embarking on some really interesting things for 2013, which I can't really allude to at this point, but in the provider space, in establishing networks and relationships with providers that are to the benefit of our members. Because what we then do is we give the member a guarantee that they can utilize any provider, but we don't want the benefit of that to sit in the scheme. We want the members to experience the benefit of that through a price reduction. So that they then see, okay, if I make this choice of going to this provider, my premium becomes cheaper. And to use the kind of car insurance example again, we're used to paying excesses on car insurance. So I can take that excess away, but my premium becomes more expensive. The bigger my excess, the cheaper my premium. So we kind of give the member that flexibility and that choice. In the provider negotiation, if I can kind of use that metaphor, is we allow the members to make the choice. If you want to use a particular provider, use him, but then you must be prepared to pay a particular price. We've negotiated another set of providers for you. If you're prepared to use those, your price is cheaper. You don't get any less benefit from it. You just give up a bit of your freedom of choice. And for some people, that's actually a relatively easy thing to do, because the doctors or the networks or the hospitals or the dentist, whatever it may be, are relatively close by to where they live. And that becomes an easy choice for them. So it's about having those providers in the right places for the membership. And we think historically we've proven our track record in those components with the provider choice model that we have. And we still believe that is a way in which we can innovate our product even more going forward.
Thanks, Damian. Yeah, I think anybody who's familiar with your scheme would agree that you've done a lot of work there. Just in closing, what would your message be to the employer groups out there as far as the current medical scheme arrangements go?
I think for employer groups that are on our medical scheme, there are some really strong advantages about being on Momentum. Those provider choice components that we provide can really play around with your increase. So we might see an employer group in our space who's saying, geez, I can't afford a 10% increase, but the employees aren't accessing that provider choice in a meaningful way. So non-chronic people are paying for benefit that they shouldn't actually have. So we've actually done quite a lot of work within our own database of employer groups to say, with help of the advising community like yourselves at PSG, is to be able to say, are you buying the right product for yourself? It might change over time, but buy it now, the right one for where you are in your life stage. And a lot of our employer groups during the course of this year will probably be able to have really low single-digit increases if the members in their groups do the right thing. For employee groups who aren't on Momentum Health, is really be careful about how you compare Momentum to the other options that you may be using, and you look at those provider components that we already have built into the product to maximize, the premium that you're getting, because you can't do what you can do in our medical scheme in any other one because of some of the features that we have through Health Returns, Health Saver, and provider choice. So there's a lot of value to be had within our product if you utilize it properly. And we really see the value of some of our employer groups now. Some of our employer groups are going to get a 3 and 4% increase this year, which, John, to be fair, in the healthcare industry is actually unheard of. To be CPI minus for some people in the healthcare space is unheard of. And there's employer groups within our environment who will be able to do that relatively easily and without impacting their benefit. That for me is key. We see lots of low increases, but schemes cutting benefit in order to still make the stuff relevant. And I'm not knocking that, because we've spoken about how mature the industry is and so on. But in our environment, without reducing benefit, to still have a low increase is something which I think employer groups can get comfort with in our space. And to know that we have the youngest top 10 medical scheme in South Africa gives them a lot of security about the future sustainability of the scheme. 2 or 3 years of really solid financial results as well demonstrates some of the things that we're doing within the scheme are in a really good place. So to the employers that are with Momentum Health, you're really in a good space. For some of the others who aren't, have a look very carefully around what you're getting for what you're paying, and maybe there's some value, and go and look at advisors who have the ability to unlock that value for you.
Damian, thank you. I'm convinced that the employers sitting watching this are going to derive a lot of benefit from your insights, and just to say closing thank you, appreciate your time.
John, thanks very much. It's always great to have a discussion like this about our industry, so I really appreciate you giving us the opportunity to do that.
Cheers.
The full implementation of national health insurance is perhaps not something we will see in the next 20 years, But it is clear that some form of a public-private partnership is required to ensure that the desired outcome of the proposed NHI system is reached. And although the way in which medical schemes operate may change, there is widespread agreement that they will continue to exist for at least as long as it takes the Department of Health to address the current shortcomings in the public sector. Join us again on PSG Health Insights as we review the vital signs which drive costs in medical schemes.